Well, good morning, good morning. Good to be with you. I'm grateful for the chance to be able to present the update for the SMSNA position statements. And we'll have some details here today. The formal position statements won't come out until about 2 months or so from now. Try to forward here. So I think this clicker isn't working right now, just so you know. So by way of disclosure, so I do have investigator-initiated grants with Endo Pharmaceuticals, and at Pathway Medical, I have ownership shares. It's held in a blind trust, and we'll be talking about Shockwave and PRP off-label specifically for this lecture. So as far as back in 2021, the SMSNA released its original position statement on restorative therapies. But since that time, there's been numerous additional randomized controlled trials which have been released, including an EAU statement that specifically says that shockwave therapy is able to induce a mild improvement in erectile function among patients with vasculogenic ED. That led to the impetus to saying, all right, it's time to update this and see if any new data would change our original opinion on things. Oh, there we go. So by way of methods, so we have to go back a bunch here. Can you go back 3 slides or 3 clicks? Right there, okay. So we hired a formal methodologist. It's the same individual that was used by the AUA guidelines, and we came up with 2 PICO questions. The first one was specifically, in patients with ED, does shockwave improve MCID when compared to sham? The second one was, well, what does the sham response look like? If we look at historical shams, what would we expect with a shockwave type study? We got a 40-page evidence report used to craft the updates, but there were inadequate studies to warrant a PICO for PRP and stem cells, so we just did those manually. So by way of background, the IEF-EFD is the gold standard for diagnosing or monitoring ED. That's the 6-item questionnaire. It's the only measure where MCID is defined and universally accepted. Now, this is a critical concept because MCID is the minimum. So it's not the optimal. This is the minimum threshold that's required to consider a therapy effective. With mild, you're looking at a 2-point difference, moderate 5-point, severe 7-point difference there. And so that became our key defining criteria. If a therapy fails to achieve MCID, even if it's statistically significant compared to placebo, it is not effective. So that was our minimal threshold to consider something effective. So when we got this 40-page document, we looked through it, and there were 5 major methodological flaws that we saw pretty much pervasive through almost all of the literature that we looked at. I'm just going to highlight. There were more than that, but 5 key ones I'm going to highlight. The first major one is a lot of studies used IEF-5. Now, that's a wonderful scale. There's no issues with it specifically, the scale itself, but there were 2 different versions they used. One was an actual shim. The other was basically the first 5 items of the 15-item IEF, which is not valid. But the problem with the IEF-5 is that MCID has not been defined. This becomes a major problem when you're trying to do meta-analyses because with this scale we have MCID, this one we don't, and there's not a one-to-one matching that you can do. Second major issue is the cohort description, and I'm going to try to highlight a couple of them here. So in the Fojeki studies, 2017 and 18, they considered the IEF-EFD less than 25. But that doesn't make any sense. There's no category less than 25 when you look at it. And then they picked 5 randomly as the MCID, which again doesn't make any sense. It should either be 5 for moderates, 7 for severes, and 2 for milds. But this group includes a smattering, and it doesn't include all the milds. Calvianecus, same issue. They picked IEF-EFD of 6 to 21. That makes no sense at all. It doesn't include some of the milds. It doesn't include some of the severes. And so what do you do with this? Can you really use 2, 5, and 7 if you're cherry picking certain groups in there? Olson 2015 said an IEF 15 of less than 20. Again, that makes 0 sense at all. It's not backed up in any literature. And they picked the MCID of 5 and 10. I don't even know where 10 would come from, with that. So this is the literature that we're dealing with and trying to decide, is this legitimate or not? In 2022, Calvianecus actually used a legitimate criteria, so 11 to 16, with 5 as being the MCID. That's accepted, that's correct. But when you look at the results, their treatment showed 79% met MCID with shockwave. That's better than IPPs. And when you look at sham, 0% met MCID. That's the worst sham in history. So the data is not looking good, as we start to parse through. And I'm just cherry picking a few items here. Third major issue is placebo response. So we looked at 118 studies that were used for PDE5 inhibitors, randomized controlled trials, and said, what kind of a placebo can we expect? Now, pills generally have the lowest placebo response. If you take a mechanical therapy versus a pill, pills have lower. So we said this is the lowest of the low that we would expect. And in that, we found that we expect a 1.64 typical, ranging from 1.2 to 2. But in shockwave, we found that they were 1.1, and several had no placebo response at all. And if anything, when you look at well-done studies like Masterson's study, their placebo response was about 4 points. So that's what we truly expect when we're seeing these. I just want to highlight one more. So this was a PRP study, and you can see the PRP patients at the first, third, and 6-month follow-up, they had exactly the same responses. That's incredible. You have 50 patients that all have filled out the questionnaire exactly the same at all of these time points. Not only that, but their interquartile ranges were exactly the same, meaning essentially this is the exact same responses each person's putting. Even better, placebo at baseline 1, 3, 6 months had exactly the same, both their medians as well as their interquartile ranges. This is statistically impossible, to have happened. And so when you look at it, it raises this question. Do we have to accept a study just because it got published? They somehow snuck it past enough people to get it published. Do we have to now say, oh, now we have to consider this as an average? Well, many groups do when they're doing meta-analyses, but we said, no, that's dumb. Like, we're not going to, if it's clearly wrong, we don't necessarily have to accept it in there. So fourth major issue, study power. Statistically significant does not necessarily mean that two groups are different. You'll commonly see studies that have 10 to 20 patients in them, and they'll claim statistical significance, but they're not sufficiently powered. It's very, very common, particularly in the Peroni's literature. And when you do a study, if you've ever done a prospective or randomized trial, it's common that you'll see statistical significance in your first 5 or 6 patients. That's not uncommon at all. But once you get up to 80, 90, 100, then that starts to get more correct. So we said you need to do an a priori power analysis is critical, and responsible medical journals will not permit statements of efficacy without concomitant sufficient power. So this is the biggest one. This is where I want to spend the rest of my time before finishing. So the fifth major issue we ran across is this concept of comparing responders. So this is a new thing that really popped up in the shockwave and PRP era. So it's basically saying, oops, sorry about that, what percentage of men in each group reached MCID rather than actual MCID differences. So if you look here, for example, at this data set, we have 10 people here. If I said the MCID was 2, I would claim 50% responders. If I said 5, I would claim 10% responders. But the actual median difference here is 1.5. This group does not meet MCID, even though you may claim 50% responders here. Now, why do we care? Because it's a statistical manipulation that you can do to try to prove efficacy in a therapy that didn't actually meet efficacy. So to highlight this, let's say we had a treatment group of 1,000 and a sham of 1,000. Both of their IEF-EFD was +1. So there's no MCID. But this group may have 40% responders. This may have 37% responders. Because it's so big, statistically, you have a possibility of concluding that there's a statistical difference between groups and say, hey, this therapy is effective. But higher variability will give you a higher response rate, just as the nature of it. And it also becomes an issue of means versus medians. To highlight that, you can see this is a highly variable therapy, but you have 60% responders if you set it at 2. You've got your 2, 3, and 2. Here, you only have 1 responder. So you may conclude and say, aha, 60 versus 20, there's a difference here, when in reality, your MCID median is 2 versus 1 here. And again, even as low as 30 patients, you're going to find statistical difference in these groups. Now, this becomes a particular issue when you're doing meta-analyses, because now you're getting into the thousands of patients realm where you're going to be able to do this kind of statistical manipulations to try to prove something that isn't truly there. So what do we consider an MCID for differences between responders? If there's only a 1% difference between groups, is that enough? What about 10, 20, 50? What do we set it at? Well, we don't know. It's never been defined. There's not an MCID of responders that's out there. We could set an arbitrary number and say, okay, we're going to consider this 20, based on the endo kind of concept, but it still doesn't deal with high variability of therapies. A good example is this second to last bullet. If a chemotherapy prolongs life by 1 year in 40%, but it shortens life by 1 year in 60%, you're clearly not going to accept that as a chemotherapy, but it will show a 40% responder rate. That's the variability and the impact that you'll see with that. And you particularly see it with mechanical therapies because the person feels something happening, you're much more likely to get this variability in IEF spread. So it essentially, all of this that I mentioned just negates the entire concept of MCID through statistical means. So you're flipping it in a way where you can negate the actual concept of MCID. So we created a new position statement that's going through the approvals right now that specifically says, what does any therapy need to do to be able to conclude efficacy for erectile dysfunction? And we said it needed to have a median, difference between groups, post-treatment comparison. So there's 3 items there. It needs to use the IEF EFD, not the 5, SHIM, EHS, and so on. Has to be adequately powered, needs an appropriate placebo and sham response, and it needs to meet MCID compared to the other therapy post-treatment. So if your treatment's +4, your placebo's +2, that means your final is +2. Now, if you have a mixed grouping, so you're 50% mild, 50% moderate, then your MCID would need to be 3.5 in that case. So basically, you do a weighted average to figure out what your MCID would be in that case. And then as far as the restorative therapies position statement, the key concept is whether these therapies achieve MCID compared to sham. They either do it or they don't. And we do take the reliability of the study into consideration. And we figured that the burden of proof is on the therapy claiming efficacy, not the other way around. And so we're anticipating these final statements within the next 1 to 2 months. And with that, I thank you for your time.